Hello, this is Dr. Bhaumik, the professor of pediatrics and retired Colonel U.S. Air Force. And at present time, I'm also retired from University of South Alabama College of Medicine. And today we are going to discuss about precocious puberty. As you know, in my last lecture, I did discuss about the delayed puberty. So this is just right that we do discuss about the precocious puberty. But before we go to that, let's talk about the sequence of puberty and the timing of the puberty of girls, just to refresh our memory. The breast budding is the first sign of puberty, and that usually occurs after the age of 8, but usually average age of 10, and pubic hair follows after breast development. Menarche occurs average age of 12 years in this country in North America, but it coincides with the stage 4 breast development, and the growth spurt occurs before the first menstrual cycle. What about boys? In the boys, normal sequence of puberty is that testicular enlargement is the first sign of puberty, and it usually occurs 9 years and after, but in an average is about 11 or 12 years, and that followed by the genital enlargement, changes of the external genitalia, and the best way to remember the testicular volume 4 and 6 ml herald puberty. That's the beginning of the puberty. And pubertal growth spurt in boys actually varies significantly. Some could be early, some in mid-puberty, some could be at the later part of the puberty. So what is the definition of precocious puberty? The definition of precocious puberty in girls, in Caucasian girl, is less than 8 years of age. That is the breast budding, the first sign of puberty. And in African American, even in majority of the pediatric endocrinologists now agrees that usually 1 year early, around 7 in African American. But for your board examination, by the best answer probably will be the precocious puberty is breast development before the age of 8. But for boys, the definition has not been changed for a long time. Is the onset of pubertal development or testicular enlargement less than 9 years of age. So today I am going to talk about central precocious puberty. Central precocious puberty, by definition, it means the puberty is mediated through hypothalamic, pituitary, and gonadal axis. And the maturation is usually complete if it is not interfered, and it usually follows the pattern of normal sexual development only. The only difference here is that it's early, before its time. So how common is the precocious puberty? It is estimated to be about 1% of US population may be affected by precocious puberty, and it is difficult to get a good estimation of this condition because in many cultures, ethnic groups, Southeast Asia, the premature sexual development may be considered as something is secret, and they don't like to bring it to the attention of the pediatrician, or they might not even see the doctor. And many a times that there is a family history, and since most of the precocious puberty in female is idiopathic, and so they don't take it seriously, and so somebody in the family may have precocious puberty, like a grandmother or one sister or aunt. They say, well, this is how they are. So it is very hard to get a good estimation. But there was a NIH data that the range was very big, 1 in 5,000 to 1 in 10,000. And if you go back to the family history, there is as much 25 to 30%. There is a family history or familial incident of precocious puberty. So, if you talk about the pathology and etiology, the organic cause of precocious puberty in female is no more than 10 to 20%, and the pathology in male is maybe as much as 50%. So organic pathology, even in girls, to find a cause is going to be much higher if the patient age is 4 or less. So if a girl comes with the precocious puberty and they are 3.5 or 3 years of age, and you don't need to worry about that organic pathology. But for boys, at any time, the chances of having a organic cause is always remain high. And as this slide says, as much as 90%, 95% are idiopathic in females, usually after the age of 4 or 5. So, what is the etiology of central precocious puberty? As I have mentioned, that most of the time it is idiopathic, or may be considered as constitutional. That means there is a family history, and that becomes easy that once you have a family history. But what are the other causes of precocious puberty, or what we like to call the organic causes? And the first on the top should be the CNS lesion. Most common the lesion that we have found in central nervous system in both boys and girls is hypothalamic hamartoma. And any kind of tumor, neurofibromatosis, arachnoid cyst, trauma, infection, and radiation for malignancy, and they all is associated, may be associated with precocious puberty. But let me stop here a little bit and talk a little bit about the hypothalamic hamartoma, because that's the most common cause of precocious puberty, organic cause of precocious puberty. And this one is many people consider as accessory hypothalamus, a mixed tissue benign neoplasm of mixed tissue. Is not malignant, but it's just under hypothalamus, and it regulates FSA, the GnRS pulsation, and it can actually make its own. So as a result of that, the GnRS pulsation may occur when it's not supposed to be. And there is a triad of finding to make the diagnosis of hypothalamic hamartoma, and the one is laughing seizure or called gelestic seizure, and that may occur, called laughing seizure or crying seizure, precocious puberty, and developmental delay. But not all three will be together. Primary hypothyroidism, that's another cause. That's if it is severe primary hypothyroidism and high TSH level can cross-react with FSH receptor and can produce the ovarian enlargement and the estrogen production. As you know that FSH, LH, TSH, these are glycoprotein hormone. They have the same alpha chain, only one amino acid variation in beta chain. So this has been reported, hypothyroidism with breast development or testicular enlargement, and they reverse back to normal once the thyroid treatment is initiated. So another one could be a combined. Combined by that I mean if somebody has late onset congenital adrenal hyperplasia, male or female, what might happen is this. If it's not untreated, the bone age or bone maturation go ahead, advance. And as you know, the hypothalamic pituitary gonadal axis listen to the bone maturation, not the chronological age. So which in the beginning started as a peripheral precocious puberty, if not properly controlled, now they turn out to be a true puberty or central precocious puberty. We also know that children with cerebral palsy of any reason and after having a very bad injury, they may also develop this precocious puberty. Now there is a genetic cause, and that has been seen, the mutation of the MKRN3 gene, and this gene is located at chromosome number 15, and it is called Macron ring finger mutation gene, and this is most likely responsible with control of GNRI's pulsation, and if there is a mutation, then that inhibitory effect of GNRI's pulsation, which is a hallmark in prepubertal time, is not there, so they may have precocious puberty. And there are more than 20 gene mutation has been reported in the literature. This is a patient of mine who was 3 years of age and came to see me because of the breast enlargement, and as you can see that she's in almost early stage 4 breast development, and the workup did show that she had hypothalamic hamartoma, and when she was like a year old she had also seizure disorder which was continuing, and when I saw, she still was having seizure. So when you come across a patient with precocious puberty, and what kind of diagnostic evaluation will be appropriate? Well, first of all, before you do any diagnostic evaluation, the clinical evaluation is important. As I have said, that age of the patient is important, especially in female. Good physical and neurological examination. Growth velocity, as you know, all the children with precocious puberty, they increase their growth, height velocity, and as a result of that, bone age is advanced, and so although they are universally taller than their peers of same age, same chronological age, but they all at the end is not going to be very tall. Indeed, they may be short. So next you should do a good physical examination to determine the tenor, staging of breast development and pubic hair, and testicular volume definitely, and the stress penile length in male, and a good neurological and ophthalmological examination. If you don't feel doing a very good ophthalmological examination and not be very comfortable about that, is perfectly okay to get a consult from ophthalmologist. So this is the type of thing that you can see that right here a patient, this will be increased growth periods up right here is taking turn, and then see at the end is not going to be very tall, and there may be some weight gain also. Most of the children also have weight gain. So radiological evaluation should include bone age is the must, and that we have to determine, and pelvic sonogram or testicular sonogram or good examination is also important. If you think that these patients there is a possibility of ovarian cyst, and high resolution MRI of the head with paying much attention to the hypothalamic and the pituitary area. So before you start thinking about the treatment, it is extremely important to discuss with the family that what is pros and cons of therapy, and ultimately decision of treating this patient, if there is no organic cause, will actually also depend upon the family. I have come across a situation where pediatricians sent patient for the evaluation. After thorough evaluation, it was found this puberty is idiopathic in these girls, and then you explain the treatment and the procedure. Some of the family actually do not want to go through the treatment, and especially those who had family history. So a lot of booklet and information is available that should be provided to the family, and also one thing should be re-emphasized. If this familial height, if this family history showed they are short, and this patient probably will be going to be short if remain untreated. At the same time, a psychological effect of in the school with the same age group of the girls who has no development versus the patient who has pubertal development, and that could be an embarrassing, and psychologically it might affect. But it also been found that there is a higher possibility chance of sexual abuse, and that has been portrayed by the family member, a little bit distant family member. So anyway, it will be, this patient is actually best managed by the endocrinologist, and so from there the decision will be made. If the decision is made, I am not going to go very details on that, but we usually use the gonadotropin releasing hormone agonist, which in the form of a depot injection. It can be given every 3 months, 6 months, surgical implant which might last up to 1 year, and the new agonists are also coming, and that might change some of the injection instead of 3 to 6 months. How does it work? It actually down regulates the GnRH receptor, and it desensitizes pituitary to the endogenous growth hormone releasing hormone. And what it does, in my judgment, is the most important was that it stopped that pulsatile secretion of FSH-LIs, because it is extremely important to have pulsation, both frequency and amplitude, to progress with the puberty. So that is stopped, and as the final result is gonadal suppression. And once you start them on treatment, how long do you continue? Well, if the family does not want to continue, then that will be one of the relative indication that you may have to listen to them. But once you have started, it's a good idea to do the complete, go through the complete therapeutic course. And usually by the time they are about 10 years of age, one can stop. But if the patient presented to you in a very advanced stage, somebody has gone up to 12. And complete recovery, once you stop the injection therapy, complete recovery of gonadal axis is expected in between 6 months to 18 months. By 2 years they are all completely back to normal the way it should have been. The next lecture will be peripheral precocious puberty, and I like to thank you for your attention.